So my position is that the role of radiation is pretty well established in gastric cancer. It's very similar to GE junction cancer that we just talked about, and there is some overlap, but I'm going to try to focus just on the gastric cancer data. So back in the pre-CT era, a second-look laparotomy was performed fairly commonly at the University of Minnesota to look for relapses and actually try to salvage some of these patients at 1 year. Len Gunderson, who is a radiation oncologist, went back and reported the data, which included the pattern of failure of patients. And you can see from this slide that the dominant pattern of failure was local regional. The red dots are local failures. The green dots are nodal failures, and then there's also distant peritoneal failures. So a very good rationale to include chemoradiation in gastric cancer based on the pattern of failure that was established with second-look laparotomy at 1 year. The initial studies for adjuvant treatment in gastric cancer were postoperative chemotherapy studies, and there were many of them, 20 or so randomized trials looking at postoperative adjuvant chemotherapy. And if anything, there was maybe a minor benefit in survival in the single-digit range based on this meta-analysis, and there are others. But basically, the difficult challenge is giving postoperative chemotherapy after gastrectomy because those patients lose a lot of weight and are just not good candidates for postoperative therapy in general, chemotherapy in general. The MAGIC trial, which I'm not going to dwell too much on, had this same problem. It did establish the role of perioperative chemotherapy in patients with resectable gastric cancer. But the compliance was a limitation in terms of the postoperative chemotherapy that was delivered. 86% completed the preoperative chemotherapy, and 91% of those who started the chemotherapy completed all 3 cycles, but only 57% of patients commenced postoperative chemotherapy, and 43% completed all 6 cycles. The main reasons for not starting postoperative chemotherapy were progression, death, and patient compliance issues related to complications from the surgery. So I really just want to focus on 2 trials, and one with the previous speakers have really talked a lot about is the STAL trial. But and I know it's a GE junction trial, but I think these are the trials that have compared chemotherapy alone to chemoradiation in the postoperative setting. The STAL trial was a neoadjuvant study. In the ARTIST trial, this is a study as opposed to the McDonald trial, which I'll mention in a little bit. This is a study of patients who had D2 dissection from Korea, and patients then were randomized to Xeloda and cisplatin chemotherapy versus postoperative chemotherapy and radiation with, again, the same chemotherapy. And what you can see on this slide is that patients who had node-positive disease, which is the majority of patients typically, had a disease-free survival benefit in that subset. Overall, there was a separation of the curves with the D2 dissection, but the subgroup of patients with node-positive disease did appear to have a statistically significant disease-free survival benefit. Overall, there was a trend to improvement in survival with the addition of radiation, and potentially a better powered study could have shown a benefit. There was a significant improvement in disease-free survival in the node-positive patients. The one caveat, of course, is that these patients are from Asia. There could be some differences in that population compared to Western patients. The STAL trial, as always mentioned, as was already mentioned, was a neoadjuvant study comparing chemotherapy alone with cisplatin and 5-FU compared to chemoradiation. And although, and this has already been discussed, but although there wasn't a statistically significant difference, there was a separation in the curves, and this study was underpowered to see clinically relevant differences. But again, a direct comparison in patients with GE junction adenocarcinoma with or without radiation. Intergroup 116 is the trial that established the role of radiation in this disease. It was a randomization of initial resection followed by chemoradiation with bolus cisplatin 5-FU versus observation. The patient characteristics are shown here. This was a trial of very advanced gastric cancer. 85% were node positive, and 80% were distal stomach lesions, which is a little bit different than the populations that we see today with there's a migration towards the GE junction currently. The results, which are now updated with 10-year follow-up, have held up with a disease-free and overall survival benefit that you can see here. 41 versus 50% 3-year overall survival, a similar benefit in relapse-free survival. And this, again, held up with more follow-up. So one of the things that is important to recognize, and certainly these patients were operated in a different era than currently, but it's probably not too different today, is that even though in the trial it was recommended that a D2 dissection be performed, only 10% of patients actually got a D2 dissection. So this is not non-compliance on the protocol. This is really pattern of care information, because patients were enrolled after surgery, and surgeons didn't really change what they did based on whether or not the patient was possibly going to go on a clinical trial. But it indicates that the D2 dissection, at least at that time, was not a very common operation performed. And the majority of patients had less than a D1 dissection, which is basically just taking the stomach out and whatever nodes come out with it. So I would argue that radiation is even more important in the settings where D2 dissection with a formal node dissection of the second echelon nodes is done. That's probably still true today. David may comment on that, but I think the academic centers, I think D2 dissections are very common, but I would argue in the community, most surgery is done in the community, and I would argue that D2 dissection is not the standard in all the centers. Now, toxicity was a limitation. GI and hematologic toxicity rates were extremely high, and it was difficult to get patients through treatment. But there were only 3 patients that died from chemoradiation, and a minority of patients completed all of the planned therapy. So conclusions from the Adjuvant Intergroup 116 trial is that adjuvant chemoradiation improved overall survival and disease-free survival, and that D2 dissection was uncommon. D1 or less than a D1 was more common. The toxicity in the postoperative setting with the chemoradiation the way it was given, I think was acceptable but significant. I would argue that with modern radiotherapy techniques and infusional chemotherapy rather than bolus chemotherapy, the toxicity rates are lower. But this trial did establish the role of chemoradiation as standard of care in the United States. So, and just in conclusion, I think there are 2 direct comparisons that I focused on here, the STAL trial and the ARTIS trial, that have compared chemoradiation to chemotherapy alone in the adjuvant or neoadjuvant treatment of gastric and GE junction cancer. And they both suggest that chemoradiation adds to overall survival. The best results may actually be forthcoming with trials that have been designed to kind of integrate these 2 concepts of perioperative chemotherapy and postoperative chemoradiation, in particular the Critics trial, which is looking at neoadjuvant chemotherapy and then a randomization of chemoradiation versus chemotherapy alone. Thank you very much for your attention.